So now let us discuss with the auscultation of the chest. What should be the patient position while auscultating the chest? The patient should be sitting comfortably while we do auscultation of the chest. And we auscultate on the anterior. We auscultate on the anterior chest, axilla, and the posterior chest. While auscultating anteriorly, the patient should be sitting comfortably and hands in the anatomical position. While auscultating the axilla, patient hands should be held on the back of the head. Both the hands should be held on the back of the head so that we can auscultate the axilla properly. It is similar to that of the percussion. While auscultating the posterior chest, the hands should be crossed and placed on the knees. Patient should be leaning forward. Patient should be leaning forward with neck slightly flexed. So the position of the patient while auscultating, anteriorly the patient should be sitting comfortably and hand by their side of the body, that is the anatomical position. While auscultating the axilla, the patient hand, bilateral hand should be on the back of the head. And while auscultating the posterior chest, the patient should be leaning forward and hand pressed on the opposite knee. So it separates the scapula and gives us a broader area for auscultation posteriorly. So what are the breathing advice? You should keep the patient before auscultating. Ask the patient to breathe from mouth. You should ask the patient to breathe from mouth so that any sound which is produced in the nasopharynx while breathing from the nose does not interrupt your auscultation. So ask the patient to breathe quietly from mouth. Then you should auscultate with the diaphragm. Diaphragm of your stethoscope. Diaphragm of your stethoscope. You should auscultate as the stethoscope contains two parts. One is the bell, which is used to hear the low pitch sound, and the diaphragm, which is used to hear the high pitch sound. So you should use the diaphragm of the stethoscope to auscultate the chest. And there should be no clothings. There should be no clothings. The diaphragm should directly touch the bare skin. There should be no clothing before auscultation of the patient. So, as we know the examining anatomy, we have already discussed the examining anatomy of respiratory system in our first module. If you have not seen that module, please go and see the module before coming to auscultation. Let us revise the examining anatomy of the respiratory system. As we know that the right side of the lung contains three lobes, upper lobe, middle lobe and lower lobe. And the left side of the lung contains only two lobes, that is the upper lobe and the lower lobe. So if you are examining the right side of the chest, anteriorly, if you are examining the right side of the chest, you will get any pathology of the upper lobe of the right side, and this is the left side, upper lobe of the right side and the middle lobe. If you are examining the lower part of the chest anteriorly, you will get to hear any middle lobe pathology. If you are examining the upper part of the right chest, you will get to hear the upper lobe pathology. If you are examining the axilla, the upper part of the axilla correspond to the upper lobe, the middle part of the axilla little bit correspond to the middle lobe, and the lower part of the axilla correspond to the lower lobe right side. Similarly, if you are examining posteriorly on the right side, the upper part correspond to the upper lobe and the lower part correspond to the lower lobe. The upper part correspond to the upper lobe and the lower part correspond to the lower lobe posteriorly. So And in left side, if you are examining anteriorly on the left side, upper part correspond to the upper lobe, and the lower part, there is, as we know, the lower part, most of the part is covered by the heart. So if you are auscultating anteriorly, the left upper part correspond to the left upper lobe, and similarly axilla correspond to the upper lobe, middle lobe, lower lobe, both left side and right side, and posteriorly the upper lobe and the lower lobe, both left side and right side. So only difference is on the right side. Right side, when you are auscultating the upper right side of the chest, it corresponds to the upper lobe, and the lower part correspond to the middle lobe. And similarly on the left side, the anteriorly, the upper part correspond to the upper lobe, and the lower part there is heart, so there is not much of the auscultative finding of the lung. And axilla, it corresponds to the upper lobe, middle lobe, lower lobe. Posteriorly, it corresponds to the upper lobe and lower lobe. So this is the examining anatomy. This is the examining anatomy of the respiratory system. How is the sound produced? What is the mechanism of sound production? What is the mechanism of sound production? The sound which we are going to hear, that is the known as breath sound. How this sound is produced? The breath sound, it is produced in the upper airways. Breath sound is produced in the upper airway, that is the trachea and large bronchus. Large bronchus. Normally, as we inspire air from the environment, this air, when entering the tracheobronchial tree, gets a narrower passage, as the external environment is a big environment. It passes through the large cavity, that is the nasopharynx or the oropharynx. So when the air passes from the nasopharynx, that is the larger part of the airway, that is the nasopharynx, and when it reaches the trachea and the bronchus, it becomes narrower. The trachea and bronchus are narrower than the nasopharynx or the oropharynx. So there is turbulence created in the upper airway, that is the trachea and bronchus. The turbulence of the air which is passing from a large airway to the smaller airway, the turbulence is created. So sound is produced because of the turbulence created in the upper airway. So sound is produced. Sound is produced in the upper airway. Now the sound which is produced in the upper airway will transmit through the alveoli or the small airway. Will transmit through the small airway, alveoli, alveoli, alveoli up to the pleural cavity, and then to the chest wall, then to the chest wall. So the sound which is produced in the upper airway, that is the trachea, large bronchus, will transmit through the small airway, alveoli, pleural cavity, and the chest wall. And we place the stethoscope on the chest wall and we hear the breath sound. So normally the sound is produced in the upper airway, it is transmitted through the small airway, alveoli, pleural cavity, and then to the chest wall. Then we get to hear the sound which is produced in the upper airway on the chest wall by auscultating through our stethoscope. So if there is any pathology, in the small airway, if there is any pathology to the small airway, if there is any pathology to the alveoli, or if there is any pathology to the pleural cavity, the normal sound which is produced in the upper airway will not be transmitted normally to the chest wall. Normal sound which is produced will not be transmitted normally to the chest wall if there is any pathology in between the transmission of the sound from the small airway to the chest wall. So what are the pathologies and what are the changes which will lead to altered breath sound or which will lead to abnormal breath sound, which we will discuss in this module. So normally you have to understand that the sound is produced in the upper airway, which is normally transmitted through the small airway, alveoli, and pleural cavity. So normally when this sound is transmitted through small airway, alveoli, and pleural cavity, it gets little bit filtered. The normal sound which is produced in the upper airway, while transmitting itself from through the small airway and alveoli, it gets little bit filtered, and what we hear on the chest wall normally through our stethoscope, it is a filtered sound. It is a filtered sound. Normally the sound is filtered through when it is passing through the small airway and the alveoli. It is filtered. So whatever sound produced in the upper airway while transmitting itself from the alveoli and the lung tissue gets little bit filtered and then reaches the chest wall. And when it reaches the chest wall, we hear it with our stethoscope. That is the filtered sound. So what is normal breath sound? Normal breath sound. Normal breath sound is the vesicular breath sound. What is the characteristic of this vesicular breath sound? Vesicular breath sound, as we know that the respiration contains two phases, that is the inspiration and the expiration. So vesicular breath sound is a sound which is longer in inspiratory phase and shorter in expiratory phase. We can see by this graph that the inspiratory sound is longer in expiratory phase and shorter during expiratory phase. And there is no gap. There is no gap between the inspiration and expiration. And inspiration is slightly of more intensity, which means that the inspiration is little bit louder than the expiration. So when we take a breath, when we do respiration, it has two phases, inspiratory phase and expiratory phase. So the inspiratory phase, when you auscultate, it is little bit of longer duration, it is little bit more intensity, and expiratory phase is little bit of shorter duration and low intensity than the inspiratory phase. And there is no gap. When you auscultate, you will not find any gap between the inspiration and expiration. Just as soon as the inspiratory sound will end, the expiratory sound will start, and you can differentiate. While the patient is inspiring, you will hear the inspiratory sound, and while the patient is expiring, you will hear the expiratory sound. There is no gap between inspiration and expiration. Inspiration is of longer duration, it is little bit louder, and there is no gap. So inspiration is longer, louder, and there is no gap between inspiration and expiration. So this is the normal breath sound, which we call as vesicular breath sound. Why the name given is vesicular breath sound? Earlier it was thought that the breath sound is originating from the alveoli also known as vesicles. So earlier they gave the name vesicular breath sound. But now we know that the sound is being produced in the upper airway because of turbulence created by the air column passing through the trachea and the bronchus. So inspiratory phase is little bit longer duration, it is louder, and there is no gap between inspiration and expiration. This is the normal vesicular breath sound which we heard in the chest. So what is abnormal breath sound then? If we hear a sound in which the inspiration and expiration is of equal duration, and expiration is little bit louder than the inspiration, and there is gap between inspiration and expiration, we call this sound as bronchial breath sound. Bronchial breath sound. So what is bronchial breath sound? Bronchial breath sound, inspiration and expiration is of equal duration. There is gap between the inspiration and expiration, and expiratory phase is little bit louder. So this is bronchial breath sound. This is bronchial breath sound. Bronchial breath sound, the inspiration and expiratory phase are of equal duration. There is gap, you can see there is gap between the inspiration and expiration, and the expiratory phase is little bit of loud intensity. This is bronchial breath sound. Normally we get to hear bronchial breath sound on the upper part of the chest, on the right side where the trachea continues right main bronchus, on the right upper posterior chest we can hear bronchial breath sound. Why we hear bronchial breath sound on the right upper part of the chest? Because this is the site of production of the sound. This is the site of production of the breath sound. As we told, that the sound is produced in the upper airway. So whatever sound which is produced in the upper airway is directly transmitted to the chest wall. So as I told you, normally the sound is produced in the upper airway. It is filtered by the small airway alveoli, and then we hear on the chest wall. But if you place your stethoscope directly over the area where sound is produced, there is no filtration of the sound. Directly you are placing your stethoscope on the area where the sound is produced. So there will be no filtration of sound. So the bronchial breath sound is an unfiltered sound. We can call technically that the bronchial breath sound is an unfiltered sound. Whatever sound which is produced in the upper airway, we are hearing that sound directly. The sound is not filtered. That is the unfiltered sound. So bronchial breath sound is an unfiltered sound. When you place the stethoscope directly over the trachea, you will hear the bronchial breath sound, the sound in which there is gap between inspiration and expiration is of louder duration. It is expiration is of louder in intensity. So this is bronchial breath sound. It is seen normally over the trachea. It is seen normally over the right posterior upper chest, where the trachea continues the right main bronchus posteriorly. So it is normally seen. Abnormally this bronchial breath sound is seen in consolidation. Why bronchial breath sound is seen in consolidation? Let's suppose this is your lung. This is your lung. Let's suppose a part of the lung is consolidated. What is consolidation? That is pneumonia. A part of the lung is consolidated. The part of the lung is solidified because of pneumonia. Now there is no normal air in the alveoli. It is solidified. It is filled with fluid and secretion because of pneumonia. So this part of the lung is solidified. We call it as consolidation, which occur in pneumonia. So whatever sound which is produced in the upper airway, whatever sound which is normally produced in the upper airway should be normally filtered through this lung. But there is pathology in the lung, pathology in the form of consolidation. The lung has become solidified. So whatever sound which is produced in the upper airway, now this sound cannot be filtered because normal lung parenchyma is lost, which was filtering the sound. Instead of normal lung parenchyma, now there is solidified lung. So this solidified lung will not be able to filter any sound which is produced in the upper airway, and the sound will be directly transmitted to the chest wall without filtration. And the sound which is directly transmitted to the chest wall without filtration is the bronchial breath sound. So in a patient of consolidation, we get to hear a bronchial breath sound. Bronchial breath sound. Whatever sound produced in the upper airway is directly transmitted to the chest wall because of pathology of the lung, because of solidification of the lung. So we get to hear a bronchial breath sound in consolidation. What are the other conditions where we get to hear a bronchial breath sound? Is the fibrosis. If patient lung is fibrous, if the patient lung is fibrous because of some reason, again the lung is solidified, there is fibrosis, there is no air, the normal filtering capacity of the lung is lost because of fibrosis, then again we will get to hear a bronchial breath sound. If suppose the patient lung is collapsed, again there is no air, there is the filtering system of the lung parenchyma is lost because of collapse of the lung, again we will get to hear a bronchial breath sound. So normally bronchial breath sound is present over the trachea, present posteriorly on the right upper chest because of the trachea continuing as right main bronchus where the sound is being produced, and abnormally pathologically bronchial breath sound is present on a consolidated area where there is consolidation, there is solidification of the lung. It is present, bronchial breath sound is present in fibrosis and collapse because the filtering system of the lung parenchyma is lost, and whatever sound which is produced in the upper airway is directly transmitted to the chest wall. So this is bronchial breath sound. So it is bronchial breath sound is also seen in the upper part, in the upper level. upper level of pleural effusion. Why bronchial breath sound is heard on the upper level of the pleural effusion? Let's suppose patient is having pleural effusion. What is pleural effusion? Pleural effusion is collection of fluid in the pleural cavity. So patient is having collection of fluid in the pleural cavity. So at the upper part of the pleural effusion, just above the pleural effusion, if you place your stethoscope, you will get to hear bronchial breath sound. Why? Why just above the level of the pleural effusion we get to hear bronchial breath sound? Because whatever fluid present in the pleural cavity will cause atelectasis and collapse of the surrounding lung parenchyma. And when there is atelectasis and collapse of the surrounding lung parenchyma just above the level of the pleural effusion, this atelectasis or collapse surrounding lung parenchyma will act as a solidified lung, and whatever sound produced in the upper airway will be transmitted directly to the chest wall through this solidified or atelectic or collapsed lung parenchyma. So we'll get to hear a bronchial breath sound just above the level of the pleural effusion. And if you place your stethoscope directly on the pleural effusion, what you expect to hear? What you expect to hear if you place your stethoscope directly on the pleural effusion? You will hear an absent breath sound. You will hear an absent breath sound. Why we hear an absent breath sound on pleural effusion if the pleural cavity is containing fluid? Why we get to hear an absent breath sound is because whatever sound produced in the upper airway is normally filtered by the lung. But if there is pleural fluid or more fluid present in the pleural cavity, that is the pleural effusion, whatever sound produced in the upper airway, all the sound will be filtered by the pleural fluid and no sound will reach the chest wall because of pleural effusion. So in a patient of pleural effusion, that is fluid in the pleural cavity, there will be absent breath. Similarly, in case of pneumothorax, where air is present in the pleural cavity, air will act as a barrier for transmission of the sound. So in patient of pneumothorax, whatever sound is produced in the upper airway will not be transmitted to the chest wall and all the sound will be filtered by the pneumothorax, that is the air in the pleural cavity. So air acting as a barrier in a patient of pneumothorax will lead to absent breath sound in patient of pneumothorax. Similarly, fluid acting as a barrier in patient of pleural effusion, that is fluid in the pleural cavity, will act as a barrier for the transmission of the normal sound which is produced in the upper airway. And there will be absent breath sound in a patient of pneumothorax and pleural effusion. So we have seen what is bronchial breath sound and what are the conditions in which we see an absent breath sound. Absent breath sound is seen in pleural effusion and pneumothorax. So what is bronchovesicular breath sound? This bronchovesicular breath sound is also known as vesicular breath sound with prolonged expiration. Vesicular breath sound with prolonged expiration. So normally this was your vesicular breath sound, in which the inspiratory phase was louder, it was longer, and the expiratory phase is shorter. And this was your bronchial breath sound, where inspiration and expiration is almost similar. Sometimes the expiration may be prolonged, and there is definite gap between inspiration and expiration. That is the bronchial breath sound. Why there is gap between inspiration and expiration in bronchial breath sound? The gap is because the absence of alveoli, or the sound is not transmitted through the alveoli. The sound is directly transmitted where it is produced to the chest wall. So there is absence of alveolar filtering phase. There is absence of alveolar filtering phase. So there is gap. If you press directly on the trachea, there is no alveoli in between the trachea and stethoscope. So a gap is created in bronchial breath sound. We are pressing over the consolidated area. There is no normal alveoli filtering the sound, so a gap is created. That is why bronchial breath sound. There is a definite gap between the inspiration and expiration. So this was your vesicular breath sound. This was your bronchial breath sound. So what is bronchovesicular breath sound then? It is similar to that of vesicular breath sound, which means there is no gap, but the expiratory phase is prolonged. As the name suggests, it is vesicular breath sound with prolonged expiration. You can see the expiratory phase is of more longer duration. So it is a vesicular breath sound with prolonged expiration. So this type of sound is known as bronchovesicular breath sound or vesicular breath sound with prolonged expiration. And this vesicular breath sound with prolonged expiration or prolonged expiratory phase is classical of chronic obstructive pulmonary disease. It is classical of chronic obstructive pulmonary disease. Why the patient of COPD, chronic obstructive pulmonary disease, have vesicular breath sound with prolonged expiration? It is because of air trapping. As we know that there is more air trapping in patient of chronic obstructive pulmonary disease because of emphysematous changes, because of formation of bulla, because of degradation of the alveolar septum and more alveoli coming and merging together. So there is air trapping in patient of chronic obstructive pulmonary disease, and if with every inspiration some amount of air is left behind in the lung, not all the air of every inspiration is expired, some amount of tidal volume is left in the air, which lead to air trapping in patient of chronic obstructive pulmonary disease. And with time, there is more and more air trapping. So the patient, because of more air trapping, the patient will try to overcome with the more air trapping by increasing their expiratory phase. So with every inspiration, the patient will have prolonged expiration, has to overcome more air trapping and to expel more air during expiratory phase. The expiratory phase in patient of chronic obstructive pulmonary disease will be prolonged. So we are going to get a vesicular breath sound with prolonged expiration in patient of chronic obstructive pulmonary disease. So bronchovesicular breath sound or vesicular breath sound with prolonged expiration is a characteristic of chronic obstructive pulmonary disease. So in a patient of chronic obstructive pulmonary disease, we are going to get a vesicular breath sound with prolonged expiration, also known as bronchovesicular breath sound. Or we can get a decreased vesicular breath sound. Decreased vesicular breath sound. Why we are getting decreased vesicular breath sound? In some patient we may get vesicular breath sound with prolonged expiration. In other patient we may get decreased vesicular breath sound. If there is more air trapping, there is more air in the lung. And as I told you, if there is more air in the lung, it will act as a barrier, or it will filter more air. It will filter more sound which is produced in the upper airway. If there is more air in the pleural cavity in patient of pneumothorax, it is filtering all the air which is causing absent breath sound. Similarly, in patient of COPD, there is more air trapping. So the filtration part is becoming more stronger. So whatever air produced in the upper airway is getting more filtered because of air trapping in a patient of COPD, which is leading to decreased vesicular breath sound. That is, the intensity of the characteristic of the sound is like that of vesicular breath sound, but the intensity is little bit decreased. So we can say there is diminished vesicular breath sound. In a patient of chronic obstructive pulmonary disease. Some patients may present to us with bronchovesicular breath sound. Other patient may present to us with decreased or diminished vesicular breath sound. So these are the different breath sound. These are the different qualities of the breath sound which we are seeing. That is, normally there is vesicular breath sound. In patient of consolidation, we can get a bronchial breath sound. In patient of fibrosis, collapse and upper part of the pleural effusion, we can get a bronchial breath sound. Normally, bronchial breath sound is present directly over the trachea and the posterior right upper chest. So we can get a vesicular breath sound with prolonged expiration in patient of COPD. We can get an absent breath sound in patient of pleural effusion and pneumothorax. We can get diminished vesicular breath sound in patient of chronic obstructive pulmonary disease. So what is important to look in a breath sound is the quality of the breath sound, whether it is a vesicular, bronchovesicular, or bronchial breath sound, or breath sound is absent or the breath sound is diminished. And we have to look for the loudness, that is the intensity of the breath sound, whether it is diminished or it is loud. The other point is the adventitious sound or the added sound which is present. So we can say that stethoscope is the ornament of a doctor, which no one can buy and use it, and only the clinician knows the art of using the stethoscope rightly.